So cognitive linguistic evaluation, cognitive and language. It's a little bit of a gray area on who's doing this evaluation. It can be done by neuropsych, OT, or speech based on what location you're at. It's within the scope of practice of any of these disciplines. Like Dr. Lancaster said earlier, neuropsych does a very in-depth evaluation, and it's a very appropriate referral to make. But based on where you are, the neuropsych evaluation referral can take a couple months to get into, especially if it's an outpatient referral. So if you think that a cognitive language evaluation is appropriate as an outpatient, please consider a referral to either OT or speech. And then deciphering between if it's OT or speech, evaluating for cognition and language, it really just depends on the facility. It's within the scope of practice for both OT and speech to treat memory, attention, executive functioning. So please just ask the facility on who treats those areas to find out where the referral should go. And then how can we help? We've gone over the symptoms. You've seen it on a couple slides already, but specifically for how, and I'm just going to use speech because I'm a speech therapist, how speech can help. We help with memory, attention, processing speed, executive functioning, so helping people with organizing their days. Maybe they used to be really organized at work with planning out their daily schedules, but post-concussion, maybe things just feel a little bit more scattered in their brain. This is what we can help with. And it's not just the doctors making this referral. So athletic trainers in the room, PTs, OTs, nurses, listen to your patients. If they are complaining of trouble in these areas, please contact the physicians and get the appropriate referral made so that we can get all necessary disciplines on board to get the patients the appropriate care. So speech, or OT, has been doing these cognitive evaluations in acute care, inpatient rehab, outpatient, forever. So what makes a cognitive linguistic evaluation for concussion so unique compared to a evaluation for memory, attention, compared to something like a stroke? What makes concussion so special? Well, first of all, the age groups that we're seeing with concussion is different. So the age groups most common that we're seeing with concussion would be ages 0 to 4, 15 to 19, and then 65 and older. While the ages for like a stroke are starting to trend a little bit younger, not necessarily this young, where we're seeing 0 to 4, 15 to 19. So that's something that makes concussions unique, is the age groups that we're seeing. And then the causes, the mode of injury is going to be different with our concussions. So most common causes of a concussion would be falls, motor vehicle accidents, and then sports-related injuries if it's our younger patients, that 15 to 19 age group. And then something that I've noticed while practicing is how heavily we rely on the subjective reporting with our patients. So with like our Parkinson's patients or stroke patients, we can see when we're evaluating them in our objective data what we're going to need to treat and the differences baseline and then as we're treating them. But then with our concussion patients, we really need to be asking the questions, how is this making you feel? And are you noticing a difference with this? So we really need to ask them the questions, how is this making you feel? And is this causing a change in your headache? Is this increasing your mental fogginess? Is this making you more dizzy? We need to rely on what they're telling us. So that leads me into what to watch for. Again, you've seen the symptoms, but please just talk to your patients and pay attention to what they're telling you. During your evaluation, we need to do frequent checks of their symptoms. With concussions, they're very high functioning. So they might be passing the evaluation with flying colors. They could be doing, whether it's physical therapy or speech therapy, OT, they could be doing everything, and on the outside they look great. But then if you stop and ask them, how's your head? They could have gone initially from a headache rating of 2 and jumped up to a 5, just from one simple task. So you need to pay attention to their symptoms during your evaluation. At Methodist, we go by a rule of 2. So if they come in with a headache rating of 3, we try our hardest to stay within a 2-point increase across all of their visits. If they have PT, OT, speech, we are going to try to keep them within a 2-point increase by the time they leave. Ideally, we don't want any increase in symptoms. That's our goal. But we are not going to push them beyond a 5 if they're coming in with a 3. If they reach a 5, then we stop activity and we let them rest, and hopefully their symptoms will subside with a short break. So rule of 2 for not increasing symptoms or pushing them too much, and then just frequent breaks during the evaluation or during treatment sessions to make sure we're not exacerbating their symptoms too much. So pay attention to your patients, pay attention to their symptoms. All right. Can you guys hear me okay? I know I have a really soft voice. Okay. All right, so getting into the evaluation, every good cognitive linguistic evaluation should consist of at least these 4 parts, and we're going to jump into each one. Start by talking to your patient, and Dr. Lancaster, you kind of talked about this first part, is the interview, which is so important, talking and listening to your patients. How have their symptoms changed since the injury? Have their symptoms gotten worse? Have they gotten better? It depends when you see the patients. At what point are you seeing them? 2 weeks following injury, 2 months, 2 years? What makes their symptoms worse? What are their triggers? And that will kind of lead you to what demands do they have? Are they working? Should they be working? Do they need accommodations at work? Are they in school? Do they need accommodations at school? What are their grades like? What were they like before the concussion? What kind of classes are they taking? Are they taking a pause from school right now? Did they take a break from school right after the injury? What are their study habits? Are they involved in sports? Should they be involved in sports? Do they need to take a break? What was their memory like before the concussion? Maybe they're complaining of memory now, but when I have people tell me they're having trouble with memory, I want to know what their memory was like before the concussion, because some people will tell me, well, it wasn't even that great before. So that's important for me to know. And then, are they driving? Maybe they're driving during the day, but they're not driving at night because the lights are bothering them. And if they are driving at night, maybe they shouldn't be. So educating the patient on what could be triggering some symptoms that maybe they're not even realizing right now. And then questions that you should be asking in every evaluation, like how are they managing some ADLs like finances, medication, cooking and cleaning, and is their attention and memory affecting that now? Finding out if they had any baseline testing done. So some of our younger patients have baseline testing done in the schools, and that's great to have for information on how things have changed post-concussion, but a lot of our adults don't have that. That's done through impact testing in the schools. And then getting relevant history on what could be prolonging their recovery, the things that Dr. Lancaster touched on, like are they a female, do they have a history of migraines, anxiety, depression, just knowing your patients and what could be affecting your plan of care. All right, and then getting into a symptom checklist. I have a list of various symptom checklists here. I'm not saying that one is better than the other, and this is not an exhaustive list. But if you are choosing a symptom checklist, make sure it includes those 4 categories of the different types of symptoms. So make sure it has the physical, cognitive, affective, or emotional, and then sleep. And then I'm going to show you some of the different types of checklists that you could use just to give you some examples. And then most symptom checklists for concussion go on a scale of 0 to 6. Usually we think of a Likert scale rating things on a scale of 0 to 10, but for some reason these go from 0 to 6. So the SCAT-5, which came from that sideline evaluation, has a rating of symptoms. And then over here on the left is, no, that's your right. Yeah, is impact. And that's what we use here at Methodist just because that's what our physicians use, and we like to be consistent when we're tracking symptoms over time. This is the ACE, which is another sideline evaluation. So this is just the symptom portion of that. This one is different because we're not rating on a scale of 1 to 6. We're just marking if symptoms are present versus not present. And then you have the graded symptom checklist. If you can see it on the top, it's more acute times, like 2 to 3 hours post-injury and then 72 hours. But then at the bottom, it does say that you should continue to use it during follow-up appointments. The concussion symptom inventory and the post-concussion symptom scale. They all have very similar symptoms. Okay, and then going into the formal assessment, I just want to preface this with the sideline assessment is different than the full evaluation that we're doing in the clinic. The sideline assessment is excellent in helping to identify whether a concussion is present or not and knowing whether we need to remove people from play and refer people on for further assessment. But that is completely different than what I'm talking about today for the full cognitive linguistic evaluation. So we should not be using the same tools that were used on the sideline to evaluate our patients in the clinic. So like the SCAT-5, the ACE, those are great for the sideline and then maybe just for a quick screen in the office, but that's not what we're doing during our cognitive linguistic evaluation in the clinic as a speech therapist or maybe as an occupational therapist. Those are just quick screeners. They're great to use on the sideline, but not during our full evaluation. That's not enough to do. And then on the same note, a cognitive screener such as the MoCA or mini mental slums, maybe that you're familiar with like in acute care or for some of our like dementia screeners, those again are not enough for our higher functioning concussion patients. Research has shown that our concussion patients are so high functioning that their deficits do not show up between baseline pre-testing versus post-testing post-concussion. So we need to be doing full battery assessments when they're in the clinic. And we need to include that interview and symptom checklist to really do our full battery assessment. And we need to be diving into their symptoms when we're evaluating them. So these little one-page assessments, such as the MoCA, the slums, the mini mental, are not enough to be evaluating our patients. So we need to do more for our patients than these screeners. So I'm going to give you some examples of what would be more appropriate than the screeners that we might be used to doing. Again, like with the symptom checklist, this is not an exhaustive list. These are just some examples of batteries that might be appropriate. I'm not going to go into all of these. Hopefully you have the slides if you want access to some of the tests. I just want to point out 2 of them on here. Some pediatric tests are a little bit harder to come by than the adult assessments. So the PTBI, the pediatric test of brain injury, is for ages 6 to 16, and then the case 2 is 5 to 18. So those are normed for younger ages. And then I'm going to just give you an example of what some of these other assessments are. Even if you're not a speech or an OT doing these evaluations, it'll just give you an idea of what exactly is going on in the room when you're referring these patients. Okay, so here is the BCAT, the Brief Cognitive Assessment. Brief Cognitive Assessment Tool. It looks very similar to those assessments I said you should not use, the MoCA, but it's a little bit more in depth. So it looks at orientation, attention, word fluency, but I like this one because it looks at memory, which is what a lot of our patients are complaining of. It looks at verbal recall, visual recall, and then it does immediate story recall and delayed story recall. And it's also front and back, so it takes a little bit longer. So I can look at cognitive endurance. I usually stop halfway through and check how my patients are doing with their symptoms to see if I've bumped up their headache or their mental fogginess, and give a break as needed. So it takes about 20-25 minutes if I'm going at a decent pace. And then usually I do get a symptom increase when I'm giving this one, and they do need a short break when we're done. And then patients will typically score pretty high because our concussion patients are higher functioning, but they will tell me when I'm done, whoa, that was a lot harder than it should have been. I shouldn't have had trouble with counting backwards from 20 to 1, or I shouldn't have had trouble saying the days of the week backwards, but that took me a lot longer than it should have. I should have performed better than that. So just, again, that reliance on their subjective reporting is really important. I like to use the River Mead. If I don't have time during the initial evaluation, this can be a great treatment tool. It is a memory test. It's a great functional test of memory. Part of it is taking belongings from the patient and hiding them around the room. And then later they have to tell you what those belongings are and where they are. And then another portion of it is you give them a trigger, and when they hear that trigger, they have to ask you 2 questions that you tell them to ask you later. You give them a first name and a last name of 2 patients that they see in a book, and then later they have to tell you what those first and last names were. And then another portion, a subtest, is you show them 15 faces, and then later, out of 30 faces, they have to pick out who those original 15 people were. Have you seen this person before, yes or no? So that's visual memory. So just an example of what the River Mead is. Trail making tests, I included this one in here. One, because it's a quick test. It tests processing speed and alternating attention. Some people call it divided attention. But this test was shown to actually pick up on the differences when patients were tested pre-concussion and post-concussion, to pick up on those subtle differences in their performance. So trail making test A, they connect numbers and you time how long that takes them. And then trail making test B, they're alternating 1A, 2B, 3C, 4D. So you just get a time. And then for some of our more advanced computerized testing, I don't typically use during my initial evaluation because it's a lot for the patients to tolerate with trouble tolerating screen time. But if you can have the patient do it, then great. But I usually use this as more of a assessment later on in the evaluation. Later on in treatment. So just to give you an example of what these are, in vision, you can test visual acuity, their reaction time, and then divided attention. They're just watching things pop up on the screen, and then they're telling you which way they see a letter on the screen, and then you start to have the letter show up faster and they have to react to it, and then you have them move their head and they still have to tell you which direction it is showing, and the divided attention part comes with the movement in the head. Dynavision, it's again reaction time, and you can do divided attention with pressing lights on a board. Okay, so the last portion to every evaluation is education. You guys are here today educating yourselves, so thank you for doing that. But please go forth and educate your patients. End every evaluation with some form of education, whether that's educating them on strategies based on something you found in the evaluation, so giving them memory strategies, attention strategies, leaving them with academic accommodations or work accommodations, which we'll talk about later today, giving them sleep hygiene techniques, talking about what to expect going forth in their recovery, or if you have time, going over some kind of home exercise that they can take with them. This is a research article. It's a little old, but it just talks about how powerful education can be in a patient's recovery. And I'll just let you guys reference that because I'm running out of time. And Impact Test has a free printable form if you need something to send patients home with accommodations, or if you need something to send to their school. It's just an easy check form if you need something to send academic accommodations to their school. Are there any questions? Okay.
Thank you, Dr. Moffitt. So as he said, I am Josiah Parker. I'm going to talk to you guys today about the role of physical therapy in concussion rehabilitation. We'll start with just a little bit about me. As Dr. Moffitt said, I have a new clinic, Elevate Physical Therapy. It's a cash-based clinic, which allows me to spend more time with my patients, which is very helpful. As you've heard multiple people talk today, spending time and being able to really get down deep into the issues that are going on with these patients is important. So it's something that was important enough to me that I started a clinic based off of that. I'm married to this lovely woman right here, Kimberly. And as of the time of making this, we were not planning on having 2 kids. But I have a 21-month-old son, Titus, that you see there. And then we unexpectedly ended up in the emergency room and had a successful C-section on Saturday night. And so Ruby Grace is in the NICU right now and recovering very well, and hopefully going to be coming home to us soon. So I also, as Tom said earlier, enjoy golfing. So threw up a little sunrise picture from Ashland Country Club earlier this year. So things that we want to cover today, we'll talk a little bit about why I got into concussion treatment. We'll talk about briefly what a concussion is. Go through my evaluation and treatment that I do with the patients that are coming to see me. Run through a quick case study. Talk a little bit about why collaboration is important, as some of the presenters have alluded to before me. Really, I got into concussion treatment just by blind luck of being in the right place at the right time. So actually the person who started the concussion focus group was leaving the clinic that I was working at the time. And so there was a spot to fill in order to continue our concussion program. And the owner of that clinic approached me and asked me to fill that role. I was very hesitant at first because I had no intention of treating concussions when I was going through school. But immediately after starting, found it very rewarding. My first concussion patient was not an athlete as you would expect because I was working at Athletes Training Center at the time. But it was a middle-aged woman who was at work and ran into a corner of a wall and still had concussion symptoms 2 months later. So you never know where you're going to get a concussion patient from. But it's fun to be able to provide guidance to these patients. There's a lot of myths out there. Being able to just provide education to these patients is fun. As many other people have talked about, these concussions, when they run on for a long period of time, bring people to a mental state where they're just not themselves. And so being able to see that change and get people back to being themselves is also something I enjoy. And then I like to call concussion treatment the Wild West of medicine, because there's a lot of things that are left to be researched, and so there's a lot of creativity that comes with treating these patients, and I really enjoy that piece. So we've talked a lot about what a concussion is already. I was really hoping that Dr. Moffitt would wait and not bring up his pregnancy test, because that was my laugh that I was hoping to get on this slide, but oh well. But the most important thing to me on this slide is that concussions are a rehabilitative injury. So there was a point in time where we thought we stuck these patients in a dark room and we wait until they start to recover, but we're not in that time frame anymore. We talked about the 3-day rest period and getting people back to activity. And so I think the most empowering thing that we can do for these people is to let them know that there are things that they can do in order to get back to their lives and their jobs and the things that they enjoy faster. So when it comes to concussion recovery, as Dr. Lancaster said, 3 to 4 weeks is kind of the normal recovery period. I'm typically seeing people outside of this period. So typically someone who's coming to see me has had these symptoms for 3 to 4 weeks. They're getting frustrated with where they're at and wanting to get back to their activities. We've talked several times about the fact that a loss of consciousness is not predictive of how significant the concussion symptoms are going to be or how long they're going to last. But when I went to a couple of my continuing education courses, dizziness is the one that they pointed out as the most significant factor. So I would say 95% of the patients that I see say that sometime around that time, first 5 to 10 minutes after their concussion, they felt really dizzy. So I would say that's also proven true in my practice. And then you can see a couple other of the risk factors for prolonged recovery there. So one of my first steps when I was getting into treating concussions was to go to the University of Pittsburgh and learn from them because they've done a lot of the research on treating concussions. And so this is a slide that I stole from them. So they list some of the risk factors on the left side. You go through, you have a concussion event, and then once you come in and we are evaluating those patients, we're grouping them into these different areas in order to help establish what we're going to do with these patients. So in my screen, I'm going to go through and look at every one of these areas, and I would also add exertion into that list because getting people back to tolerating physical activity is also a very important part of what I do. So for my evaluation, I would echo what many people before me have said. Subjective history is extremely important. Getting a really good idea of where this patient has been and where they want to be is extremely helpful as far as the treatment process goes. So I spend a lot of time asking about pre-incident history. Like I said, a lot of these patients are coming to me, they're 3 to 4 weeks out already. Things are a little bit blurry for them at that point of what their normal is. But if I'm asking somebody and then they've been working for 8-9 months, I've had a patient come in a year after a concussion incident. They don't really remember what normal was for them anymore. So the sooner I can get an idea of what they remember as normal, it helps me to understand what we're working towards. So as Dr. Lancaster said, being able to document that and refer to that later is helpful for me as I'm trying to get towards discharge with that patient. Then I move into the post-incident history, looking at what are their chief symptoms right now. Are they having issues with sleep? Are they having issues with headaches? Are they having some depression issues? Talking about what activities they are in now, as well as what activities they want to get back into in the future. Whether it be an athlete that is trying to get back onto the field, or a train controller who's wanting to be able to tolerate looking at a screen and seeing scrolling numbers going by all the time. Just really have an understanding of what that individual patient needs to be able to do on a day-to-day basis. And then being able to make that tangible for that person and set goals of, all right, successful therapy for you looks like what? What will you be able to do at the end? And that really helps to get that patient involved in that process. From there, we move on to the objective portion of what I'm looking at. And so we'll talk a little bit more about this later, but cervical symptoms can really mimic a lot of the concussion symptoms. And so being able to, on day one, look at, are you having pain with turning your neck? Are you having pain with palpation over the muscles around the neck? Does neck movement increase any of your symptoms? I don't go through a full cervical evaluation on that day, but it's enough to let me know, hey, do we need to dive into this more as we have subsequent visits, or is this something that they're doing pretty well on? We'll go through a cranial nerve screen. That piece really doesn't change a lot as far as my treatment, but it's important for me to know if I need to refer that person to somebody else. Not every time that I get a patient does it come from somebody like Dr. Moffitt or Dr. Lancaster who have already screened that person and I really feel more comfortable with where they're at. I've had people find me off the internet and not have seen a provider before. And so being able to know who I need to get that person to in order to make sure that I'm being safe with that person is important as well, since Nebraska is a direct access state for physical therapists. I like to go through the vestibular ocular motor screen. So I will look at saccadic eye movement. So I like to use a metronome in order to give myself objective data. So both on the saccadic eye movement and the vestibular ocular reflex testing, I like to try and shoot for that patient being able to tolerate 180 beats per minute, which is pretty quick by the time that they discharge. Now, when somebody walks in, I'm not going to start at having them try to complete that test at 180 beats per minute. I have arbitrarily chosen 90 beats per minute as the start point for me. But I'll have them holding up 2 pencils or pens or their fingers and bounce their eyes back and forth to the beat of the metronome for 20 seconds. I always educate people that if they're really getting a lot of symptoms during that first test, stop and let me know. Because as Jamie alluded to, I don't want to overly exacerbate their symptoms. Another strategy that I use is if they have issues with the horizontal, I'm not going to test vertical on day 1. We have a lot of things to get through. And again, just like Jamie said, my rule is 2 as well. You know, if they get to a 3, they need a break. And if we can't get them down from a 3, I'm probably just going to educate them and tell them we'll pick this up next time that you come in. VOR is just simply looking at an object and keeping the eyes focused while getting the head turning. Again, I'm using that to the beat of a metronome. With convergence, I'll use fingers or number 2 pencil works because I like that number 2 is about a 14-point font, which is what they've shown in the literature is kind of a good target. And so I'll have them hold 2 objects, bring that first object in towards their nose, and let me know, 1, if they can see 2 objects in the background, because if they don't, then I know that they are probably suppressing out of one of their eyes and not using their binocular vision. But 2, when that front object becomes blurry, and then I measure how far away from their nose they are, and under 6 centimeters would be the normal range for that test. Then for visual motion sensitivity, holding an arm out and focusing on the thumb, and they're rotating their entire body, so they need to be able to focus on that object and cancel out the fact that everything in the background is moving behind that. And the goal for that one is to get them to 60 beats per minute without increasing their symptoms. I'll then use some pieces from the SCAT-5, running through the symptom checklist, the short-term memory, the concentration and delayed recall. Just as Jamie said, being able to ask a question after every section or couple sections and ask, has your headache gone up? You know, are you feeling nauseous? Are you getting any additional symptoms that you didn't have before? Is important because it's going to determine how quickly we go through this evaluation process and potentially how much we get through. I always tell my patients, we don't have to get through all of this on day 1. We just need to get through what you can tolerate. And if you're having a lot of symptoms, we know that you're coming back anyways. We can finish the rest of this later on. I'll go through a balance screen, and we'll look at both static and dynamic balance. So for static balance, I'm looking at the best test. So I'm looking at double leg support, feet right next to each other with eyes closed. Tandem support, 1 foot in front of the other. Then single leg support, both on a firm surface and then on a foam surface, for which I use an Eric's pad. And I score that on a scale of 0 to 60. So 0 would be the best possible score, meaning they didn't lose their balance at all during that test. 60 would be the worst, meaning they lost their balance at least 10 times on each situation there. And then I'll go through a dynamic balance screen and just look at their tandem gait, look at the quality of that motion. Are they able to look up? Do they feel like they have to focus on the ground, or can they look at a different target? Are they wobbling quite a bit? Are they able to keep their feet on that straight line while they're doing that test? Then we get to the exertion portion that I alluded to earlier. So this is one of my favorite pieces of what I do with my concussion patients. I did not have this piece when I first started treating concussions. And once I found it, it dramatically changed my results with patients as far as getting them back to their activities more quickly. And it really doesn't matter whether it's an athlete or somebody just working in their normal day job. Being able to get people into that subsymptomatic exercise is a huge piece of their successful recovery. So Dr. John Leddy, who's been brought up already today, came up with the Buffalo Concussion Treadmill Test. And it's really looking at cerebral blood flow, not measuring that per se, but his concept behind it was that if we can regulate that cerebral blood flow better, those patients are going to feel better. So it's kind of like somebody trying to go from a couch to 5K. You're not just going to have somebody who hasn't exercised in quite some time go out and run a 5K as their first step. We might start with them walking around the block and building up to the point where they can walk a 5K and then start the running portion of that. So with that treadmill test, it's somewhat similar to a cardiac stress test, in where I'm going to have them walk on a treadmill at their normal walking speed, usually somewhere between 3.2 and 3.6 miles per hour. Every minute, I'm going to increase the incline of that treadmill by 1%. While they're walking, I'm looking at their heart rate. I'm asking them what their rate of perceived exertion is. So on a scale of 1 to 20, how hard do they feel like they're working? And then I'm monitoring their headache. So the great part about this test is I don't need to have somebody walk in the clinic and be absolutely symptom-free in order to complete this test. As we talked about earlier, getting people moving more quickly is helpful in the recovery process. And so I might have somebody walk in and have a 4 out of 10 headache. As long as there's not a lot of other confounding factors, I will more than likely still get them on the treadmill. But I'm using that 3-point increase as my rule. So the test stops if their headache increases by 3 points, so that's 1 point above what I typically try to keep people at during their treatment session. If their headache increases by 2 points and they add an additional symptom, such as nausea, dizziness, or something like that that wasn't there before, or if they reach an RPE of 19 or 20 out of 20, which means they're just working really hard. So at the conclusion of the test, for any of those 3 reasons, I'm going to document what their heart rate is, what their headache is, and what their rate of perceived exertion is. And then based off of that, I'm able to assign them some subsymptomatic exercise in order to get them moving. You can see the article for reference there. It's also listed in my references at the end of the slide there, or at the end of the presentation. So once we get through all of that, which depending on the person, as I said, we may not get through all of that in day 1. But regardless, I will definitely get into the education on day 1. So I don't always have patients come from somebody who's educated them on what they should be doing or what they shouldn't be doing and what things to expect post-concussion. And so I treat all my patients the same, and I give them all this very similar spiel. So I talk about sleep hygiene, making sure that they're going to bed at a similar time, making sure that they understand that naps, although important, should not affect their nighttime sleep. So if somebody comes in and says, oh, I can take a 3-hour nap, but then my 10 o'clock bedtime turns into a midnight bedtime, then I'll tell them, hey, why don't you set a timer and take a little bit shorter nap, and let's see if we can still get that 10 o'clock bedtime. And then also just making sure that their screens and devices are off, 30 minutes to an hour before bed so that they can wind down and be able to get a nice restful night of sleep. I talk about water intake. What I always tell my patients is the brain is surrounded by a bowl of water. So if we are dehydrated all day long, it's just another factor that is irritating those symptoms. So we want to control everything that we can control. So I tell them to try to drink at least half their body weight in ounces every day. So for some people, that might be using an app. For some people, they're already doing that. For other people, it's just having a water bottle that they carry around school or work all day long. We'll talk about the exercise in the next slide. But symptom management strategies are also very important. So getting people to understand life is not the same right now as it was before your injury. So just like when you have a broken arm, you can't go out and throw a baseball. You may have to change some of your activities due to the concussion. So 2 activities that seem to be really irritating for a lot of my concussion patients are driving and walking through the supermarket. So I give them the example. If you drive to the supermarket, walk through the supermarket, and drive home, and your headache goes from a 3 out of 10 to an 8 out of 10, that might incapacitate you for quite some time. You might have to, take a nap, rest for a little while. But if we can instead drive to the supermarket and have that headache go from a 3 to a 5, sit in the car, maybe listen to some soft music, close your eyes for a little bit, bring that headache back down, then we'll go walk through the supermarket, again, rest in the car before you drive home, and then do that drive home. You might get home and have a 5 out of 10 headache, which is a lot more tolerable and able to get you back into your next activity a lot more quickly. So that's just one example, but just trying to help people understand ways to control their symptoms during the day. From there, I assign exercise based on what I found during the evaluation. So typically the first place I like to start is that subsymptomatic exercise. So I would like them to exercise 20 minutes per day. I give them, so once I take that heart rate at the end of the treadmill test, I will take 80% of that, and that's what I recommend as the heart rate that they maintain during that 20 minutes of exercise. Not everyone has access to a heart rate monitor, but due to the Apple Watch and Fitbits and all those kind of things that have been very popular these days, most people do or can obtain one relatively easily. If in the worst case scenario they don't have a heart rate monitor, I'll educate them on that rate of perceived exertion scale, and I can match up because I ask consistently through that test, how hard are you working, and monitor what their heart rate is. I can try to match up what rate of perceived exertion they should feel when they're doing that exercise. So helping them to understand, hey, you weren't working really, really hard at that time. We were just walking at a 2% incline, but you were tolerating that well. That's what I want you to maintain for that 20 minutes. Also educating them on where they're doing that exercise is important. So you might be able to tolerate 130 beats per minute for 20 minutes. But if you're going to Lifetime Fitness and you're in the middle of all the other meatheads working out and you've got music blaring and everything else, you might still have a headache. But that headache might not be because your heart rate was where it was, but it's because of the environment that you're in. So if somebody has a bike in their basement and they can go to a place where it's pretty quiet and exercise, they're going to get better results on that front end where they're symptomatic than they are trying to go to a big gym. Then the exercise or the tests that I use for saccades and convergence and those kind of things will become exercises as we move forward. I don't consider myself an expert in vision, but I am able to get patients started, and I also understand when I need to refer that person on to somebody else. So I don't try to eat that whole load, but I can get people empowered enough to be able to start doing something about some of the vision issues that they have. Ultimately, I educate them that 2/3 of the brain's pathways are dedicated to vision, and so it's going to take a while for that vision to feel normal again, and it's usually the last thing to resolve for those concussion patients. Potentially giving them some balance exercises, some things to address some of their cervical discomfort, and then like I said, there's lots of different reasons that I'm seeing people, so just getting creative on what those other exercises may be. Here's a visual representation of some of those exercises. So you can see up here the saccadic exercise. So you're holding those two objects and bouncing the eyes back and forth. Looking at another level of that would be holding the head still and moving that card back and forth while tracking it with your eyes. I don't typically start with that one. I typically start up here and then progress to this. That VOR exercise that I talked about, so holding that card or the pencil or the thumb still and then moving the head back and forth or up and down. And then next level for that one would be that now you're moving the card and your head, so now you've got to track while that movement's going on, which is significantly difficult, and again, not one that I typically give out. Actually, I've never given out on day one. The past slide alluded to the Brock string, so here's a good example of the Brock string. So when the patient is doing that exercise, this is what it'll look like. There'll be beads on the string. I'm asking them to focus on one bead while they hold that string up to their nose. And so the image on the right is what this should look like to the patient. Again, I want them to be using binocular vision while they're doing this, so they should see a V going in and a V coming out from the point that they're looking at on the string. If they don't, again, I know that they are suppressing one of their eyes, and I have some tricks that I can use to help to try and wake that up for them. Just a couple of pearls based off of things that I've gleaned over time and things that I've heard over time. We've talked a little bit about memory. So we go through 3 different stages when it comes to memory: encoding, storage, and retrieval. So what I like to tell people is fuzzy in, fuzzy out. A lot of people that are coming in with concussion don't have physical damage to the structures of the brain that are in charge of memory. Obviously, we've talked some about the fact that the neurotransmitters and those kind of things aren't working as well as normally or overworking. But if you're having headaches and dizziness and nausea and difficulties focusing when you're trying to memorize something, it's going to be hard for you to store that, and it's going to be even harder for you to pull that out later on. And so if we can clear up some of those front-end symptoms for people, a lot of times those memory issues will start to resolve because they aren't having such a hard time trying to encode that information. We've talked some about cervicogenic versus concussion symptoms. So neck pain can totally mimic a concussion. So I've had patients come in, they've had a concussion in the past, they've recovered from that concussion, and 2 months later, all of their concussion symptoms come back. They'll come back, they'll see me, I'll do a cervical screen, and literally I've had people in one session, by only treating the cervical symptoms, say all of my symptoms are gone. So because of that, I know that it's not just a concussion that we're dealing with. They're having a hard time understanding where those symptoms are exactly coming from. So being able to provide treatment for that and then also educate people on that dynamic. As several people have said, collaboration is extremely important when it comes to concussions. So I think one of the biggest ways that I've grown as a practitioner is knowing who to refer to. So even this morning, learning a little bit more about some of the things that are happening in speech therapy. Typically when I bring that up to patients, they're like, well, I talk fine. Because they don't understand, the breadth of what a speech therapist can do. And so being able to understand, okay, this is what a speech therapist can do. They don't just talk or work on the quality of your ability to talk, but they can work on some of those concentration issues, focus issues, and help you to get back to maintaining your schedule or being able to memorize something for a test. And so I don't need to be an expert on on how to treat all of those issues, but I do need to be an expert on who I can refer my patients to so that they are able to get the highest level of care that's possible. Also being able to know some of the pre-concussion status. So I don't have the pleasure of being able to work with most of my patients before they have their injury. So if I can talk to someone like Tom in the athletic training room, then I am able to know a little bit more about what that person was like prior to their concussion, and it helps me just have a better picture of what they should look like once they're done with treatment. And then well-done treatment takes time. So you need to be able to sit down, talk to that patient, block out an hour, and really be able to get to the bottom of what issues are going on for that person. So just a quick case study. 20-year-old female. She had her fourth concussion over a 2-year period of time. She was hit in the head by a basketball by her 4-year-old sister, so it wasn't a significant amount of force, but it was enough to bring back some of her symptoms. She was a very bright student. She was tolerating classwork once she was there, but she was unable to even tolerate walking across campus. So she was late for any class that she had to get from one end of campus to the other, because she would literally have to stop and take breaks because she would get up to an 8 out of 10 headache just from walking across campus. Clearly because of that, she was also not able to exercise. She'd been seen by a chiropractor and a physical therapist for neck issues, but they weren't trained at all in concussion therapy. So I was the first one really being able to help her with that. On the first day, her treadmill test results, she was only able to get her heart rate to 130 beats per minute before we hit that 3-point increase in her headache. So I prescribed 20 minutes a day of her heart rate being at 105 beats per minute. Not very high. So we're talking, slow walking for her was able to get that heart rate up to 105. We also looked at some of the saccades and gaze stability. She was barely tolerating 90 beats per minute. She had a lot of symptoms with that, and she still had some mild cervical symptoms, even though she had gotten some treatment for that. 2 weeks later, her heart rate was now, she was now able to tolerate 160 beats per minute. So we changed that home exercise program to 130 beats per minute. I added in some postural correctives to try and help some of the neck discomfort that she was having. 2 weeks after that, we were able to start doing some resistance training. I educated her on the fact that this is not going to be your normal trip to the gym where you're trying to push as much weight as you possibly can, but very subsymptomatic body weight for a lot of her exercises, but allowed her to start just kind of getting a taste of getting back to what she wanted to. 2 weeks after that, she had some regression. So she was having some nausea. She had thrown up twice over the weekend. So we were able to kind of get to the bottom of that and found that some lack of gaze tolerance was really a big part of her issue. And so added some of those exercises in. A month after that, she was able to tolerate a heart rate of 174 beats per minute on the treadmill. And we stopped for the first time because her RPE got so high and not because of her headache. But she was still having difficulty with workouts. So I, again, reiterated the fact that you can't just go do whatever you want to do right now. We've got to keep these exercises subsymptomatic. And so her final numbers, 11 visits over 3 months. She was 80% better at the time. She was no longer having issues getting across campus. She was back to working out 4 times a week, just being selective on what she was doing. Not having any consistent headaches, just with a long day of tests or high-intensity workout. And she had improved saccades and gaze stability both to 170 beats per minute. I did actually end up getting a follow-up with this patient a couple of years later as she had a little bit of a setback due to some cervical issues. And so she was back to 100%. She was doing all exercising as normal, no longer having any sort of headaches, and again, back to school without an issue. So some people have lingering symptoms, but she was able to get completely over all of them, which was great. So that's all I had for today. Thanks for everyone for your time. If you have any questions, I can answer them now or I can chat with you afterwards.